Good morning, everyone. Thank you for joining us today. I know this is the last day of Astro, so everybody's getting their last-minute meetings in, and we're delighted to have you as part of our Industry Expert Theater today. I'm Robin Walker. I'm the SGRT Development Manager, and the SGRT community will be hosting this event, but it's sponsored by VisionRT. We're delighted to welcome our two amazing presenters, Josh Heinzerling from Living Cancer Institute and Josh Yamada from Memorial Sloan Kettering. They will both be presenting on stereotactic radiosurgery with evidence and experience with surface-guided radiation therapy. So we're very, very excited. We will be asking questions after each speaker. So once Dr. Heinzerling is finished with his first presentation, we'll open the floor to questions. So again, thank you for being here, and please welcome Josh Heinzerling.
Well, thank you. I appreciate the opportunity to speak today, and I'm going to concentrate mainly on stereotactic body radiotherapy and integration of SGRT and how we've done that in our clinic, and show some data we've acquired just to show the reliability and usefulness here. So the objectives I'll be talking about, first I'm going to review SGRT use and daily setup prior to IGRT for SBRT. This is meant to limit interfraction shifts. And then I'll look a little bit at some data for SGRT and continuous monitoring during SBRT treatments to detect interfraction motion. Show again some data quantifying that in comparison to repeat IGRT. We'll also talk a little bit about SGRT for respiratory motion management during SBRT and review potential benefits for breath hold during SBRT as far as organ at risk toxicities. So why integrate SGRT into SBRT? Well, we know SBRT necessitates a high degree of confidence and accuracy through all phases of the treatment. This is driven by integration of immobilization. We use IGRT prior to treatment, but it also includes treatment planning and dose delivery technologies. Immobilization is very important, obviously, to reduce interfraction and intrafraction motion, but it can't eliminate it. IGRT can ensure accurate tumor positioning prior to treatment, but IGRT incorporated in the treatment process during treatment often requires additional technology. It can require invasive procedures or technical challenges. It also has challenges during the treatment, including collisions between imaging arms, as well as subjecting patients to additional radiation exposure. So starting first with patient setup prior to SBRT, we integrated SGRT early in our process. When I first arrived at our clinic, we were doing SBRT typically with setting up the patient marks and then doing additional KV imaging prior to cone beam CT. The shifts we saw on average were typically 15 to 20 millimeters from patient marks. And it was a very inefficient process. So it was a two-step IGRT process. Oftentimes, when there were large shifts, the therapist had to go into the room to shift the patient, and it just led to a lot of inefficiencies in the process. So once we acquired SGRT and integrated it, we first looked at how can we utilize this to reduce interfraction shifts prior to cone beam CT. The process we use is very similar to a process for other sites where SGRT is used, including breath hold for breast or simple setups for head and neck open mask. We define a region of interest. Some of the caveats for SBRT are it's very important to exclude items that are not part of the body that may be part of the treatment setup, such as the compression paddle or arcs. We then set up patients to the DICOM, and then after cone beam CT, we correct the position of the target and then acquire a respiratory gated surface in the treatment position. So this allows us to get a new reference where the patient is after cone beam CT. Most of what I'll talk about initially is going to be in free breathing patients, and then we monitor those free breathing patients with SGRT and gate the beam if necessary. So when we first started acquiring data, we compared the two-step IGRT procedure that we were doing prior to SGRT integration and compared that to SGRT followed by cone beam CT. We did this in about 58 patients, 71 lesions treated. This is all body radiotherapy, and I'll go over location here in a second. So again, patients were initially set up to external marks, and then they were alternated between KV-KV pair or SGRT, followed by cone beam CT. We recorded the additional shifts required for cone beam CT and compared those to see how close they matched. We also looked at a lot of different patient factors that may affect setup, tumor location, patient weight, BMI, as well as range of motion of the tumor itself. Here's just a schematic of what we did. So again, patients lined up to marks. They alternated between taking a KV-KV pair or lining up with SGRT, additional cone beam CT to confirm target location, and then we acquired those shifts and compared them. So here's our data. This is actually presented by my physicist a couple years ago at Astro. You can see the method of KV-KV mean shifts in the second column there compared to SGRT in the third column. The first thing to notice is how small the shifts are in general. So in every parameter, we're essentially less than 5 millimeters for additional shifts on cone beam CT. There was really no difference between the two methods utilized, except for a slight difference in longitudinal shift of about 1 millimeter. This included lung, liver, adrenal, and spine tumors all treated with SBRT. So based on this data, we really started integrating. We got rid of the two-step IGRT process. It was inefficient. SGRT we felt was obviously very reliable as an initial setup prior to cone beam CT, and it streamlined our process quite efficiently. As far as patient characteristics, you'll see a little bit of a theme in the data I present that BMI can affect some of the shift outcomes with SGRT. Although those remain small differences, they do tend to translate to higher shifts with when SGRT is used. Tumor location and range of motion were also some factors that applied to individual directional shifts. So as far as continuous monitoring during SBRT, we obviously integrated that quite early in the process, but we wanted to measure how well it was doing. So how do the shifts detected with SGRT during SBRT treatment correlate with additional imaging with cone beam CT? We set very tight margins for SBRT monitoring of 2 millimeters and 1 degree of rotation. And so if a patient is detected to go out of that range for more than 2 seconds, we actually gate the beam at that point. But we also stop the treatment and we repeat cone beam CT if necessary. So we just compared the suggested shifts. We recorded those suggested shifts from SGRT and then the additional shifts made on cone beam CT and used paired t-test to compare those. So here's basically the vector plot of all of our shift data. This includes 26 patients and 34 fractions, which is about 10% of fractions at our center where we detected intrafraction motion outside of 2 millimeters. Again, that's very tight tolerance within PTV margins, but we were able to detect about 10% of fractions that had motion outside of that. This resulted in about 75% of patients having additional clinically meaningful shifts on cone beam CT, and the comparison of shifts was very, very good as far as how they correlated, with no statistically significant difference between the two. They were right at about 3 millimeters each. Some of the things to notice, I think, on the vector plot are, one, just how reliable they are, how the shifts are very comparable, but also how sometimes with SGRT we can detect shifts that may be greater on cone beam CT. So SGRT can be very useful in detecting potential internal motion that may be happening as well. So we had a number of shifts that were outside what we would consider standard PTV margin for SBRT, and it was nice that we caught those during the treatment. If you look at some of the individual parameters of the data, looking at the vertical, longitudinal, lateral shifts, all these correlated very well with no difference between the two methods, or between the shifts detected by SGRT and additional shifts on cone beam CT. Same with rotations. Some of the patient treatment factors, again, that were analyzed, obesity and PTV size were seen to affect the differences in detected intrafraction motion with SGRT, slightly underestimating shifts seen on cone beam CT. The next steps for this project will actually be to take real-time data that we can actually get from the new upgrade for SGRT and analyze the dosimetric impact of what we're seeing intrafractionally. So with that data, we hope to actually make justification for reducing margin size, which may matter in certain tumor locations. So what about combination internal and external monitoring? So a lot of us have machines that we do SBRT on where we have the option of doing imaging during treatment. That may be CyberKnife or TrueBeam. We perform all of our SBRT on TrueBeam, and we use triggered imaging in certain cases to allow us to image during the treatment. I think this is especially useful personally in SBRT for prostate, spine. We also use it for SRS brain. So we use the same process. Patients are set up with SGRT initially. We do IGRT with cone beam CT or KV films, depending on the location. And we monitor with SGRT during treatment, but simultaneously do triggered imaging with either a bone or fiducial match. The nice thing about this is you can choose your beam hold method based on the reliability of what you think you're monitoring. So for prostate, I'll show an example of that. But essentially, since we have implanted fiducials and those can be detected by triggered imaging, we'll use triggered imaging to gate the beam. We'll still monitor externally. And I think that's important just because you're only going to image every so often. You can set your threshold anywhere from a gantry rotation to 15 seconds. But at the same time, in between images, you have a nice, reliable detection method for any motion that may be happening. So this is a prostate SBRT case. You can see here this patient had implanted fiducials. We actually did space OAR at the time of fiducial insertion. And then we utilized SGRT along with triggered imaging during the treatment process. I think hopefully this will work. This just shows, so this is actually a slightly obese patient. You can see the video here that we're monitoring with SGRT. And then in the lower, this will kind of zoom in here in a second, but the lower monitor shows the triggered imaging aspect of the treatment. So we've basically now started the treatment. Treatment's ongoing. The triggered imaging is taking images so every so often. I think we set our threshold typically to about 15 to 30 seconds, depending on the location. And it's continuously monitoring externally, but also taking images during the treatment, which continues to be very efficiently done. So I'll switch now a little bit to respiratory motion management during SBRT. So we know we have to account for respiratory motion of tumors, especially in the lung and liver. And this can be managed in multiple ways. We all have different ways of doing this, whether it be inhibition with abdominal compression, gating, or tracking. So inhibition is obviously the most crude way of dealing with respiratory motion, in that we compress the patient, which forces chest wall breathing. This can reduce motion quite effectively, but it doesn't eliminate it. So and there are situations where it actually can push organs towards our target, especially in the abdomen. And we know that patients don't love this. They can be very uncomfortable during treatment, depending on the level of which we're compressing them. Tumor tracking can be done various ways. We have systems that can implant fiducials that we track during treatment. It can be accomplished with imaging. This can be performed on Linux, but it requires a lot of additional technology, real-time visualization of the tumor, which can be technically challenging or limited by location. And then implanted fiducials can require invasive procedures that sometimes are not otherwise required, such as implanting fiducials or calypso beacons in the liver or lung, where we don't necessarily need to do that. Respiratory gating, or involving breath hold, which stabilizes the tumor within one respiratory cycle. Treatment's delivered only during the breath hold cycle. This oftentimes requires purchase of additional equipment, whether it be ABC. This is where SGRT, I think, has a real advantage in that you can utilize the same mechanism that you're tracking interfraction motion and monitoring your patients with high reliability, but also can be used for breath hold and gating during treatment. So we've started to do some breath hold cases at our clinic, both in lower lung tumors, but also in liver tumors. I thought I'd show a good example where I felt like that made a lot of sense. This is a 72-year-old female patient who had a right lower lobe lung cancer that was resected about 3 years ago, and that was found to have a left lower lobe mass that was eventually found to be an adenocarcinoma. She wasn't a candidate for additional surgery, and so she was sent to me for SBRT. So this is one of the challenging locations you can treat a lung tumor. This tumor was right on top of the diaphragm, so it had a lot of respiratory-associated motion. It was also centrally located near the aorta, the esophagus, and then inferiorly right next to the stomach. So we did a couple of CTs for comparison. So we did a 4D CT with and without compression to see how compression affected the stomach position in relation to the target. We also did CTs at max inspiration and expiration. And based off that and the volumes we saw, which I'll show in a second, we decided to treat the patient at max inspiration with SGRT used for breath hold monitoring as well as continuous monitoring during treatment. So here are the volumes that we're seeing with the compression or free breathing 4D CT. Again, you can see the ITV in the inner circle and then the PTV, which is a standard 5 mm margin surrounding it. You can see how that's dipping into the stomach, which makes the treatment planning quite difficult in regards to that being the organ at risk with the lowest constraint. Compare this to the breath hold CT scan. You can see that the inferior superior direction of the ITV is much less, which allows us to put the same, even though with the same margin, allows us to have the PTV dip much less into the stomach. So we ultimately gave a dose of 9 gray times 5 to this patient. That was mainly based off of the maximum dose constraints for the stomach, which I'll show here in a second. This is the plan. We used a rapid arc plan in this situation to try to spare both the max point but also the volumetric dose to the stomach. You can see the 45 gray line, but you see a lot of intermediate dose going into that stomach. And it's very hard when you have quite a bit of PTV overlap to really spare that portion of the PTV and really affect your volumetric dose as much. Compare this to the breath hold plan. Again, you can see we're able to spare the stomach a little bit more with the intermediate dose, and I'll show the DVH comparison analysis here in a second. But just with the reduction in the PTV overlap, it really allowed us to do better work with sparing that organ. So here are the maximum dose comparisons. If you look at the maximum dose to the stomach with the free breathing, it was about 45.7 gray. Same dose between the two versus 36.3 gray. This allowed us to treat the 9 gray times 5 fraction regimen for this patient, the suggested tolerance being 35 gray in this situation. I think more importantly, the volumetric constraints were the volume receiving 26.5 gray was really reduced with the breath hold technique. So conclusions, I think use of SGRT is very reliable and efficient for daily setup prior to SBRT. It's also a very powerful tool for detecting interfraction motion. We felt that the shifts detected with SGRT and additional IGRT are very comparable and are affected by very few things other than obesity. And then use of SGRT for breath hold, I think, is a promising technique. We're probably using more and more. We're going to start studying this in a very similar fashion just to gather data on its reliability, but maybe allowing us to reduce certainly dose to organs at risk in certain locations. And I think the combination of this may allow us to reduce PTV margins as well. That's all I have, and I'm happy to take some questions. I think he's bringing a mic, but.
Am I good?
Okay.
Thanks. I was just wondering, do you still use compression then for tumors that are higher up in the lung, like in conjunction with the SGRT?
We don't have to. We measure motion, and oftentimes we won't compress patients that have very little motion for an upper lobe tumor. Sometimes I'll use very light abdominal compression even for tumors that are in the middle lobe or upper lobe, just from a standpoint of immobilization. That's really it. But you can use it either way. So SGRT can be utilized in the compression or non-compression scenario. So either way, it's a very nice tool to have. All right. Oh, one more.
During treatment, do you do any imaging to detect the target motion during treatment, not before? I mean, like idea of cyberknife. In cyberknife, you are taking imaging during
During the treatment?
interfraction, yeah, during fraction itself.
The only time we're doing intrafraction imaging is with triggered imaging.
Yeah.
So what I showed for the prostate case, we do it for spine as well, but it's not going to track. For spine, it's not going to track. It doesn't have a fiducial to track. It just, you can put your bone contours, and we're working a lot on algorithms, and I know that they're coming out with new algorithms to do triggered imaging tracking with other locations. But as far as what's available now, you can only track fiducials with it.
Only fiducial, not for lung or?
The lung, you can't track anything. You could track a bone. Again, I think they're working on algorithms, much like CyberKnife, which tracks a tumor, to kind of broaden that spectrum of what you can do with triggered imaging.
Thank you.
Okay.
So while we're switching, I know there's a lot of you standing. If you see like an empty seat beside you, just put your hand up and let some people get a seat. Come on in.
Start the slideshow for me, sir. Give a second.
Okay, you can stand if you want to. I'm actually much more entertaining when you're standing anyways, so that's fine with me, really. All right, well, thanks for being here. It's truly an honor and privilege for me to talk a little bit about the clinical rationale for surface-guided radiation therapy for stereotactic radiosurgery. And if those of you who have participated in our recent webinar, this might seem a little familiar to you. Here are my disclosures. So I think there's no question that there's a revolution going on in the care of our patients who have stage 4 cancer. And here's just one example, and I'm sure we've all noticed this as we've now had quite a bit of experience with the use of trastuzumab in breast cancer in HER2-positive patients. As it says here, the widespread use of HER2-directed therapy with trastuzumab has unmasked a population in whom CNS progression is a significant source of morbidity and mortality, since trastuzumab does not penetrate the CNS but is effective outside the CNS. And this really puts management of brain metastasis in the forefront, because there's no question that our patients are surviving longer and long enough to develop brain metastasis in many situations where perhaps they wouldn't have had that time to develop it prior to targeted therapies. And a lot of targeted therapies are not as effective in the CNS. Some are, but many are not. And therefore, it really underscores the importance of local control of brain metastasis as our patients are living longer and longer. And so I think one of the great paradigm shifts that that our field has undergone in the past 5 years is the management of brain metastases. Particularly, what do you do about patients who have multiple metastases? Of course, we have lots of prospective, even randomized data for patients who have up to 3 to 4 brain metastases. But what about in the setting of more than 5 metastases, of which we are seeing more and more of in the clinic? What should we do for those patients? Should we consider focal treatment strategies like radiosurgery, or should we still be thinking about whole brain radiation? When you try to think of the reasons for radiosurgery, probably provides better tumor control. It's a much more ablative treatment approach than whole brain radiation, where we are able to spare uninvolved brain from significant radiation doses. I'll show you in a minute. Less toxicity. There's randomized and prospective data to suggest that that's true. And now I think with the advent of modern technology in terms of computer software, modern imaging, surface guided radiation therapy that we're talking about today, and improvements in LINAC and image guidance technology, it's now becoming more and more feasible to treat multiple lesions in the clinic. But what about the risk of micrometastases? What about the toxicity of radiosurgery and radionecrosis? Is it truly brain sparing? And you know, and it has to be practical in order to be implemented in the clinic. So I think you and I, we've all thought about and struggled with these issues as we thought about these patients. I just want to share with you one piece of data that really influenced us in our workflow in terms of how we're going to manage patients with multiple metastases. So this is a prospective multi-institutional observational study from Japan, reported a couple of years ago now, almost 1,200 patients from from 23 Gamma Knife centers in Japan. All these patients had 5 to 10 brain metastases, and these patients were prospectively followed. A non-inferiority analysis was in the publication, and really what it suggests is that the dividing line in terms of prognosis, in terms of important oncologic factors, is really, it's not 5 to 10 metastases, it's actually 1 or greater than 1. And in terms of survival and other factors such as the risk of new metastases or the risk of developing leptomeningeal disease was really predicated on whether or not it was a solitary brain metastasis or not. And so it made us think, if we're comfortable treating 3 to 4 metastases with radiosurgery, and as a LINAC user, that's really all our clinic could tolerate. Why shouldn't we be comfortable treating 5 to 10? Because oncologically, the dividing line for survival, for example, is really 1 or greater than 1. And this magic number of 3 to 4 metastases for radiosurgery, I think, was predicated more on practicality. It just was simply too intrusive into the clinic workflow to treat 3 or 4 isocenters one by one with a LINAC-based system. If you had a patient who had 10 metastases, you're basically taking up your linear accelerator for half a day. And it was just impractical. And so that limit, I wonder, came about not because of oncologic reasons, but mainly out of practical limitations of the technology. Here's an example from this paper. looking at the risk of developing new metastases, whether you have one, you have less than 5, or greater than 5 metastases. And what they found in this prospective database is that, again, the risk of metastases is more predicated on whether there's one or more than one. There's really not a significant difference in the risk of developing new metastases, whether you have 3 or 4, or you have 8 or 9. The same thing was found for leptomeningeal risk, and suggested that perhaps radiosurgery from an oncologic perspective could be a viable option for patients with greater than 5 lesions. Another, I think, compelling argument to go away from whole brain radiation in the setting of multiple metastasis are studies like this small randomized trial led by Eric Chang at MD Anderson. And there's been confirmatory trials that have been done by Paul Brown, but they all basically find that in the setting of comparing radiosurgery compared to radiosurgery and whole brain radiation, that there are significant neurocognitive benefits to avoiding whole brain radiation. This is a small randomized trial that was actually stopped early because of the significant improvement in, or the lack of toxicity in terms of neurocognitive decline in the radiosurgery arm. In this particular case, there is almost a 50% reduction in neurocognitive decline by avoiding whole brain radiation. Another interesting thing about this study was the fact that patients who avoided whole brain radiation actually had improved survival. Now, this was not for 10 metastases. These patients had 1 to 3 metastases, but still, in terms of neurocognitive decline, it does make a compelling case to consider focal treatment strategies rather than irradiating the whole brain. And when you think about it, I think all you have to do is look at a few dose distributions to see why this would be the case. I'm just going to run through a case that we treated a while ago. This patient had 6 metastases scattered throughout different regions of the brain, treated with a single session radiosurgery. The prescription dose was 21 gray to 80%. And what I've done is that I've set the isodose line, the blue line, dark blue line, at 300 centigrade. And I did that just to show you how different this would be compared to a single fraction of whole brain radiation that would be typically, let's say, 300 centigrade times 10 fractions. So here's the difference with radiosurgery, which is a single session. This is the entire treatment, compared to a single fraction of whole brain radiation, in which, of course, the entire brain would get at least 300 centigrade. Now, it is true that with radiosurgery, there are significant hotspots compared to whole brain radiation, but those hotspots are going to be centered in the gross tumor volume. So clearly, if there's a dose argument to be made, radiosurgery is significantly less radiation than a single fraction of whole brain radiotherapy. So I didn't show you the data, but certainly there's retrospective as well as prospective data to suggest that there's no loss of overall survival by emitting whole brain radiation up front and just treating with radiosurgery. There's less dose to the whole brain, there's less toxicity, particularly in terms of neurocognitive decline, but also it's been shown in other domains to be less toxic than whole brain radiation. And oncologically speaking, there's no difference in important outcome measures when you're talking about more than a single metastasis. And now that we have improvements in technology and delivery tools that allow us to treat multiple lesions with a single isocenter just as easily as we would treat a single lesion, I think that that has finally taken away the last barrier that would prevent us from considering avoiding whole brain radiation up front and treating up front with radiosurgery only in patients who have multiple brain metastases. In fact, this is choosing wisely from Astro from a number of years ago, which at that point was already suggesting that perhaps we shouldn't be considering whole brain radiation as a knee-jerk reaction for patients with brain metastases. Particularly for those of us who are LINAC users, this kind of technology, I think, has become very important. If you're a Gamma Knife user, I think you're probably used to treating multiple brain metastases and probably been doing it for a long time. But those of us who are coming at this from linear accelerators, these technical innovations have really changed the landscape and made it much more practical to treat multiple lesions. We can use a single isocenter. The treatment planning time has been greatly reduced, and we can provide plans that are at least on par with what you would get with a Gamma Knife. And the delivery of radiation it really takes up not much more time than you really would need for treating a single lesion. One of the important glues, I think, that brings this whole paradigm together is the use of surface-guided technologies. And this is important, I think, for a number of reasons. The previous speaker, I think, has outlined a lot of them. But really, what we want to be able to do is make sure that we manage and are aware of and control any positional uncertainties related with treating multiple metastases in the brain. You can imagine how much potential error there could be if you have if there's uncertainty for a single lesion with a single isocenter. If you're treating 10 metastases, you can almost multiply that uncertainty by 10 if you have a single isocenter setup and you're uncertain about exactly where each of those lesions are. That's because, of course, with the distance from the isocenter to the target, but also the fact that these targets are extremely small, and small errors for small targets can be magnified in terms of how well you're treating the lesions. And fortunately, software, I think, is now readily available that allows this to be done with minimal effort relative to what it would have taken, let's say, from even a planning perspective, to plan 10 metastases. You can't imagine I don't know if there's any planners from our department here, I hope they're not, but you can't imagine the amount of eye rolling I would get if I told them I want to treat a patient with 10 brain metastases, because it's a tremendous amount of effort to plan them sequentially one by one. This is very interesting data from the University of Alabama, Birmingham, from Evan Thomas et al. And what they were able to show is that there was, previous to these types of publications, data suggesting that perhaps MLC-based ARC therapy did not provide plans of sufficient quality when compared to Gamma Knife plans. But what the UAB innovation is that, in fact, if you pay careful attention to detail, you can produce Gamma Knife equivalent quality plans for multiple lesions with a single isocenter. And not only that, but you get significant time savings. And UAB, I think, is interesting because they were a Gamma Knife center prior to switching to LINAC-based treatment. Here's what they found for plan quality, whether it's whole brain dose, whether it's the lower dose constraints or the upper dose constraints, as well as the mean dose to the brain. There's really no significant difference when you compare the same plan for Gamma Knife or with careful attention to detail, single isocenter VMAT plans. We also know that there are a lot of limitations when you think about what we used to do with frame-based treatment. There is a geographic area that the frame can only define, and if you have a target that's outside of the frame, as far as the planning computers are concerned, it doesn't exist. Burr holes, even ankylosing spondylitis in the neck are significant anatomic barriers to treating patients with a frame. Low-lying lesions are patients who have been on steroids a long time and that you can't get the frame low enough, for example, to treat a low-lying cerebellar lesion. So for all these reasons, we really thought hard about moving away from frame-based radiosurgery. But a question we had to ask ourselves before that, because we obviously didn't want to switch to a technology that was inferior to frame-based treatment. But one, I think, fundamental question is actually how good is frame-based treatment? We often make the assumption that patients don't move in the frame because it's bolted to their skull. But in reality, when you actually look at it, there is movement even with a frame-based approach. And so for us to kind of get a basis of comparison, we did a small study and we looked at patients who were in the frame, and we simply compared their planning cone beam scan in the frame to the actual treatment scan, which we did on a cone beam scan, with the patient immobilized in the frame, and compared them. And this is probably about, at our clinic at that time, was probably about 4 to 6 hours between the time that we did this planning simulation CT and then we did a treatment cone beam CT. And so when we tried to match the planning scan here with the cone beam scan, what we found is that you can either try to match anatomy to anatomy, because the skull is a very good fiducial marker. And what we found is that we had a hard time matching both the anatomy and the fiduciary localization rods at the same time. You could have one, but not the other. So if we tried to match to anatomy, the fiduciary rods, the localization rods are off. If we match to the fiduciary rods, the anatomy would be off, suggesting that these patients in fact do move even when they're in a frame. And so for this very small group of patients, this is what we found. There are translational and rotational errors, particularly if sagittal nod was probably the biggest error that we found. So with that in mind, we then went and did another group of patients by comparing the same patient immobilized in a frame, and then we set them up in kind of a mock treatment in a frameless system just to assess what it would be for these patients, patient by patient. And to do that, of course, we use cone beam CT imaging because it provides a very detailed and accurate 3D information for positioning error delineation, and matching them very carefully, as we're all very familiar with. But we also then use, to measure the amount of motion, we use surface mapping, 3D surface mapping. And so based on this, we were able to get a handle comparing the same patient, frame or without the frame. And the surface mapping system we found to be extremely reliable tool for this, because its accuracy both for translational and rotational errors is within tenths of a millimeter or tenths of a degree. And of course, another important thing, particularly for cranial, is that you're able to monitor these patients from multiple different couch angles. And particularly for cranial, that's, I think, an important feature. So by monitoring these patients in real time, we're able to measure the amount of translational and rotational error in the frame or without the frame. And what we found actually was that the patterns of movement was individual to the patient and not unique to the immobilization system. In other words, the same patients tended to move the same amount in the same way, whether they were in a frame or they were not in a frame. The immobilization system really didn't make a difference. It was patient-specific. Now, I think that's also a very important observation to make, and why I think it's important to have some kind of way to monitor patients who are undergoing stereotactic radiosurgery in a frameless environment. And because you need some kind of system to pick the outliers, to find the outliers. Most patients are probably going to be within your tolerances, but you're going to have less than 10% of patients who are outliers. And it's important for them that you have some way of picking up patients who move excessively during the course of treatment. And so, for example, okay, so you can't see the mouse here. But anyways, you can see On the upper frame, on the frames where it's frame-based translation, and the one below it, which is C, frameless translation, you can kind of pick out which patient has that steep curve that's going up. Okay, that's the same person right there. And if you look at overall our results with this, generally these patients did very well. In terms of translation, the mean translation was a third of a millimeter with a standard deviation of 0.2 millimeters, and rotational errors were 0.2 degrees with standard deviation of 0.1 to 0.2 degrees. So on the whole, whether it's frame-based or not frameless, these patients actually tended to do very well, and we had a very good instrument, the surface-guided mapping system, to tell us that most of these patients did very well. But again, you've got to watch out for the outliers. They're the ones that are going to get you into trouble. Just to illustrate, I took a case and just kind of theoretically added some rotational error. So this is what happens if there's slight rotational error of 1 to 2 degrees to the right in terms of the location of the target. And so you can see that in the front, it tends to drift one way. In the lesion in the back, it tends to drift the opposite way with rotation. If you have two small lesions that are far apart and you're not careful, it's possible that you could miss the target. Here's an example of what we commonly see, which I call sagittal nod. Here's a case where the isocenter is set in the middle of the brain. One lesion is 7 centimeters away from the center, and another one is 6 centimeters away. What happens when you introduce a little bit of rotational sagittal error? Well, of course, the further away you get and the greater the rotation, the greater the likelihood that you're going to not treat what you think you're treating. It's highly unlikely you're going to get more than 1 or 2 degrees of rotational error. But again, you need to watch out for the outliers, and they are there. If you don't have a way of looking for it, you'll never know. And when we did frame-based radiosurgery, all we did was we set up the coordinates and measured. We didn't image. We didn't really know. But now with image guidance, there's a greater burden of responsibility that we know that we're treating what we think we're treating. And it's important, I think, that as we do this, to be able to monitor the patients accurately and in real time during treatment. And obviously, surface-guided 3D mapping fits the bill very nicely. So at our institution, currently what we do is that we've basically completely gone away from frame-based radiosurgery. It's all frameless. And although we're a cancer center, so we don't treat benign conditions, there are many centers that have moved away from Gamma Knife and who are using frameless systems to treat trigeminal neuralgia, giving massive doses near the brainstem, and they're very comfortable doing it because the extra confidence and the loss of uncertainty that real-time surface mapping provides during the delivery of 80 to 90 gray, within millimeters of the brainstem. We use VMAT treatment planning, 1 to 2 isocenters. We have a 6-degree freedom of couch, which is very helpful. And as I said, it's the surface mapping that's the magic glue that brings this all together for us. Just going to quickly talk a little about hypofractionation, because obviously frameless treatment is an advantage for hypofractionation. When you have large lesions, larger than 2.5 to 3 centimeters, I would say for most people, they would consider that a large lesion. In cases where it's reirradiation or near eloquent areas, we will often look to and consider hypofractionation. And again, with surface mapping, we're able to use radiosurgical margins with the same degree of certainty that we would for single-session radiosurgery. This is an Italian study published last year where they took their patients that had lesions greater than 2 centimeters and analyzed them according to the fractionation schedule, either single-session radiosurgery or hypofractionation, which in this case is 9 gray times 3. And so these were for lesions that were greater than 2 centimeters, and they just reported the outcomes both in terms of tumor control, local tumor control, and toxicity. So what about, first of all, tumor control? For larger lesions in this study, there was a significant benefit for hypofractionation compared to single-session radiosurgery. Why? Perhaps because of larger lesions, you have to reduce the dose. This was particularly accentuated in lesions larger than 3 centimeters, where the local control rate for single-session radiosurgery was 54% at a year, compared to hypofractionation, which resulted in local control almost 3/4 of the time. In terms of toxicity, same kind of thing. Hypofractionation provided significant benefit in terms of reducing the risk of radionecrosis compared to single-session radiosurgery, and this effect, again, was accentuated with larger lesions. Lesions greater than 3 centimeters, for example, saw a 50% reduction in radionecrosis risk by hypofractionating. The larger the lesion, the more the benefit, perhaps, with hypofractionation compared to single-session radiosurgery. So there is, I think, a strong rationale for considering radiosurgery, or at least focal treatment paradigms, even in the setting of multiple metastases. We're not seeing a loss in overall survival. It does give significant less brain radiation compared to whole brain radiation therapy, less toxicity, particularly in the setting of neurocognitive decline, but I think in many other quality of life domains that's probably true. And oncologically, no significant differences in outcomes for greater than 1 lesion. Hypofractionation, we're doing more and more of it because it's just becoming more and more feasible with frameless systems. We can still use radiosurgical margins by using image guidance and surface guidance paradigms, and it's allowed us to treat very large lesions safely, perhaps by going to a hypofractionated treatment paradigm. The last thing I'll bring up in summary is that VMAP-based treatment planning with 3D image guidance, in other words, cone beam CT with real-time 3D surface monitoring, allows for not only rapid planning and delivery, which is really a feasibility issue. We can treat patients in 1 to 2 isocenters, whereas if it took 3 or 4 hours to treat 15 lesions, patients may not even be able to tolerate something like that. But now we can almost treat them as fast for multiple lesions as we can for a single lesion. And image guidance has really given us the confidence that we can do this and that our outcomes are equivalent to frame-based treatment paradigms. Another important factor, particularly I think that's important for surface-guided radiation therapy, is that it is a completely independent check of what you're doing. And it monitors in real time, and in terms of feasibility is no longer a drain on department resources the way single isocenter treatment would have been, particularly for frame-based treatment for multiple brain metastases. Thank you for your attention. So we have a few minutes for questions, I believe.
2 questions in one. Firstly, is how many patients have you treated using this technique? And secondly, what is the patient feedback on the experience with the open face mask versus the other techniques?
Yeah, I'm sure we've treated thousands of patients with frameless radiosurgery and 3D surface mapping. Patient experience, even patients who are claustrophobic typically can get through open mask radiosurgery. On the one hand, though, I have had a couple of patients who have said, they preferred the frame. I don't know, one of them sent me a Christmas card with his head in the frame and said, "Look what you did to me." And so he was one of them, but the vast majority of our patients absolutely prefer the frameless open face mask approach over a frame-based system for those who had both, I would say. And I think, I'm sure our experience for all of us in the audience is probably pretty similar. Go ahead.
The one case where you showed the sagittal nod where the lesions were like 6 to 7 cm from the isocenter, is that where you would think about maybe doing 2 isocenters, or are you very comfortable just doing 1 isocenter for something when they're that far apart?
I think there are centers who'd be very comfortable treating that case of a single isocenter. We would probably use 2 isocenters, but I think there are very experienced centers who would be comfortable treating that case of a single isocenter.
In the case of, let's say you have 3 lesions, one lesion is like 2.5, 3 centimeters, and the other 2 are sub-centimeter lesions. Are you preferentially now hypofractionating the larger lesion and then doing a single session for the other 2, or are you treating all 3 with a hypofractionated approach?
Yeah, that's a good question. I think our practice is evolving. So assuming that larger lesion is not going for surgical resection and that we're treating it, we would hypofractionate the larger lesion. I think really for expediency's sake, from the planning perspective, we'd be comfortable treating the smaller lesions of hypofractionation, but it certainly would be perfectly acceptable to do both. So I don't really have a preference for one for the other. Because I think those small lesions will probably be well treated with hypofractionation as well.
What leaf size do you have on your accelerator?
Yeah, so we have the micro multi-leaf collimator for our TrueBeam. And I think that's a good point, actually. It's important to, I think it will be very difficult to do this kind of work for small lesions if you have, a 1 centimeter leaf diameter, for example. I think you probably need at least a 5 millimeter leaf or smaller if you're going to be doing brain metastases.
How long is your planning when you have a patient with 6 to 10 metastases? How long is the planning process?
Well, at our institution, where we have to reinvent the wheel for everything, it probably takes our planners a couple of hours to do it, but there's commercial solutions that are available that could probably do it in less than an hour.
What is the frequency in hypofractionation?
Our typical fractionation schedule, I think is what you're asking, is 9 gray times 3. We used to do a lot of 6 gray times 5, but like the Italian data, for example, we've moved to 9 gray times 3. The post-op data from Stanford, 9 gray times 3. So we've kind of settled on that as our standard go-to hypofractionation schedule. We do it daily.
Just a question. I mean, I was a little bit surprised. I visited yesterday the center with the installation of the HyperArc. And I was surprised that the surface guidance system is not working together with the HyperArc from Varian. Do you know the way to go around this problem if there is no interconnection between these 2 systems?
Short answer, no. I don't know. I wouldn't be able to say. I don't know if somebody in the audience can answer that question. Okay. Thank you for your attention. Oh, is there another question?
It looks like you're moving away from whole brain radiation therapy, even with numerous metastases that are grossly apparent on imaging in the brain. But are there patients where you would draw the line and say this patient should get whole brain radiation therapy according to, say, the disease-specific rated prognostic assessment or some other algorithm that you're using?
Sure. I think there, for example, with leptomeningeal disease, we're going to give that patient whole brain radiation. If there's a history of multiple metastases that keep coming up with every follow-up visit, I think we're probably going to be thinking about whole brain radiation. There's certain histologies, like non-seminoma germ cell tumors, or I will still consider whole brain radiation over some type of whole brain radiation over radiosurgery. But you're right, the majority of our cases are moving away from whole brain radiation. Okay, thanks everybody.